Okay, good afternoon. We are at the Oral Rehabilitation Congress in Guayaquil. It's a huge honor to be interviewing Dr. McLaren. He's received his DDS from the University of Pacific. He graduated from UCLA in Brussels. Dr. McLaren, one of the most common problems
Plus, I
in the
have
industry.
two professors too. I'm a P2, like a.
Okay. Thank you for sharing that. One of the most common problems in the industry is sensitivity. What choice do we have to prevent it?
That's a very common problem in dentistry, and I can tell you that I think we've all evolved through those issues. And I do mostly indirect restorations, but I do some direct restorations. And I can tell you with adhesion today, I have virtually zero sensitivity, virtually zero. If you choose not to, let's say, etch dentin, okay, if you believe in not etching dentin, and you use a universal adhesive, they are phenomenal, and you will have minimal sensitivity because of that. But if you choose to etch dentin, you are not a bad dentist today, even though I know there's a lot of people starting to believe that. But two things if you add to your process or your techniques. After you etch, if you use a 5% glutaraldehyde, that's a technique I learned from Ray Bertolotti. I want to give him credit for back in the 1990s. So after etching, you add a 5% glutaraldehyde for 30 seconds. Prior to that, I used 2% chlorhexidine. I think it was one of your questions in there. I'll use 2% chlorhexidine for 30 seconds after etching, 5% glutaraldehyde, something like Gluma, for 30 seconds, and then a fourth generation bonding agent, or you can use a universal with an etching technique. And if you do that and you have proper moisture control, we literally have zero, practically zero sensitivity. And I work with graduate students. I had graduate students at UCLA, now at University of Alabama, and I work with undergraduate students. And if we follow proper technique and add those products, add a 5% glutaraldehyde or 2% chlorhexidine to our technique, and obviously don't cause too much pulp damage with our processes, use proper thermal techniques, don't overheat pulps, really you can control that quite well.
Okay, and what do you think for chlorhexidine as a cavity disinfectant, or which should use today as in our protocol?
I use a 2% chlorhexidine all the time. After I prep, before I cement, I believe in it. There's a lot of very good research that supports the use of a 2% chlorhexidine to limit these nasty enzymes that are called MMPs, matrix metalloproteases, that limit their, stop their activity. And there's research on the other side of that, about that. They do kill bugs, kill bacteria. It doesn't show to be a negative. It may not be a positive, but a 30-second application after etching or before you place your adhesive doesn't negatively affect bond strength, and some studies show it improves bond strength. So I think it doesn't hurt. At least at best, it doesn't hurt. So I do use it in my protocol of cementation and adhesion.
Okay. The other question is, what is the main criteria that we have to use today to choose a ceramic system? What do you think is the main criteria that we have to consider to choose a feldspathic, IMAX, or zirconia to re-up a case?
This is one of those things, it's like the best of times and the worst of times on one level. We've got so many wonderful options in dentistry, ceramics being the area we're talking about, with choices. But to distill it down really to kind of three groups, we've got feldspathic ceramics, which are powder liquid systems, which are glass-based, lithium disilicate or glass ceramics, high-strength glasses with glass crystalline fillers, lithium disilicate fillers, and there are other knockoff competitors to that. and then zirconia materials, polycrystalline solids that we're having now various versions of that. But in this short time, I'll keep it real simple for you. You have to have a philosophy to do anything, right? No matter what we do, we have to have a philosophy. So I want to have a philosophy to be conservative. I want to have a philosophy to create the least damage for my patient. I want to have a philosophy also that my work lasts. So my personal goal is I am going to look for a minimum of a 10-year survival at a less than 1% failure rate per year. So that's how I'm thinking in my treatment process. So I'm going to choose the least invasive material based on that. Feldspathic porcelain, all of the literature shows that it works extremely well if we're bonding to enamel. So if we've got mostly enamel to bond to, I'm going to choose feldspathic porcelain. So let's keep it just as simple as possible. If we don't have enamel, and that number is somewhat nebulous, we did some research, myself and my team at UCLA, before I went to Alabama, that number seems to be around 70%. So 30% loss of enamel on the tooth. Less than that, I'm strongly considering using Emax because of its increased physical properties, but still an adhesive technique. So less than 30% or more than 30% enamel loss, I would be using something like Emax. Now, where I'm going to go to zirconia, which is a much stronger material, more resistant to fracture, is where I can't do adhesion. Those are cases where I'd be thinking about it's a PFM replacement. I'm going to more traditional sorts of dentistry, areas where I'm going to be relying on retention and resistance form. So again, real simple. Mostly enamel, adhesion, minimal prep, feldspathic, enamel, significant amount of enamel missing, but I'm still going to do adhesion, maybe bonding to mordentin, Emax type material or an Emax clone, and more conventional retention and resistance form, crown type dentistry, bridge type dentistry, zirconia, some form of zirconia.
Okay, what do you think about the advanced technology nowadays in dentistry, the digital workflow? Do you think what do you think will be the technician future with the digital workflow right now?
The digital workflow, as we all know, is incredibly evolving. It's here. It's on everybody's tongue. It's just mentioned in every sentence, really, in dentistry today. From 10 years ago, just being barely mentioned. There's a lot in that question. Absolutely, it's going to be the center of every process that we do, and the center of every process in every form of manufacturing in the future, and present and the future. So relative to the dental technician, I don't see it replacing the dental technician. I see it creating opportunities. We're going to have digital dental technicians. They're going to do the design. And for the near future, let's say at least 10 years, the digital world or the digital production, the last 10 or 20% still needs to be done by a technician or a trained person. What comes out of the machine isn't finished. And there's still a lot of design that has to go into the machine. And I have to tell you, I operate a lot in the laboratory world. Most of my friends that run laboratories tell me today they will not hire somebody that hasn't had some analog lab training, because they need to be able to understand from lab training to design in the digital world. So I see there's great opportunities. There's not going to be opportunities for waxers. There won't be opportunities for model people, but certainly in the digital design and digital finishing and things like that. So I think it'll be very, very fun and very interesting.
Thank you. And the last question is, can you share with us what are you currently working on?
Well, interesting. I started and ran a program at UCLA, and unfortunately, for reasons beyond everybody's control, it had to end. And I was a professor there, and I retired from UCLA. I'm currently at the University of Alabama, Birmingham, and so it's just a time in my life. I just turned 60 that I decided that I think that I'm going to have more impact to do my own private institute. So I'm going to be partnering with a guy named Vaughn Groh. That's his real name, Vaughn Groh, who owns a company called Damaged Goods. And we're going to be building an institute in Salt Lake City, actually, Utah, and we're going to be catering to teams of dentists and technicians starting in early 2019. We will be partnering with some universities through a continuing education environment, so look for that. It's going to be very, very fun. All right, 2019. I'm still going to be teaching most of my life, but I'm going to be doing it a little bit more in a private environment. So hope to see you all there. So it's going to be called Art Oral America. Art Oral America. Look for that name.
Thank you very much. It has been an honor to have you here, Dr. McLaren, and thank you very much for sharing with us.
Thank you. Okay.